Hi, my name is Kathy Mulcahy, and I am taping this video for Advanced Health Assessment, Nursing 516 for Thomas Edison State College. This is my patient, Mr. M. Mr. M, how are you feeling today?
Okay.
Okay, and we already did a history where Mr. M revealed that he is a smoker. He smokes a pack a day for approximately 30 years. He has a productive cough that gives him some brownish green sputum. He is not interested in quitting. He has no history of asthma, no family history of asthma or cystic fibrosis. His father has emphysema, and his father was also a smoker, but no other significant history. He is not short of breath or really complaining of anything right now. Um, so the first thing that we do with the assessment is always inspection. When I inspect, I'm inspecting for his overall color. Is he pink? Is he pale? Is he cyanotic? Is he gray? And I'm looking for the amount of effort, respiratory effort. Is he using his accessory muscles? Is he retracting? Is he looking like he's really working to breathe? I look at his posture, and he's able to breathe easily in this position. COPD patients often have a tripod position where they lean over to sort of increase the diameter of their lungs, try and expand the lungs to get a little more air in. But he's not doing any of that. um, I'm inspecting his chest for size, shape, symmetry, and all of those things are within normal limits. When I look at his AP diameter, if you turn sideways, I can also see that he is within normal limits. Um, when this diameter becomes bigger than the lateral diameter, that's how we know a person is struggling with chronic lung disease. But that is not the case here. I'm also looking to see if he's obese, which he's not. Obesity can compromise respiratory status and cause sleep apnea. I'm looking to see if his overall are the, can I count every single rib looking at him? That would be an indicator of poor nutrition. I'm looking to see if his lips are pursed. They are not. I can look at his fingers for clubbing, and I don't see any evidence of clubbing of the fingernails. Um, again, as I said, he's not really working to breathe, and everything looks pretty normal from here. His landmarks are the suprasternal notch here. Here are his clavicles. We're going to use those in our assessment. Um, his sternum is here. The manubrium is here, and you can feel there's the angle of Lewis here. Sternum goes down. Here's a xiphoid process. Coming off from the xiphoid process, I'm sorry, I don't mean to tickle you, is the costal angle. Okay? Um, while I'm looking, and his trachea here is midline. If it were shifted to the right, that's a mediastinal shift, and that can indicate either a problem with the trachea or it can indicate heart problems, other problems. I don't see any swelling, any masses, um, any superficial venous patterns that would indicate heart disease. Um, okay, so I'm also looking at his respiratory rate. Between 12 and 20 is normal for an adult. I'm looking at the rhythm. It's nice and regular. I'm not seeing any Cheyne-Stokes breathing or any um, periodic breathing, anything like that. Expiration and inspiration are approximately equal, and so that looks good. The chest movement is, easy, symmetrical, rise and fall. Um, no problems there. Um, and I don't hear him making any audible sounds that I can hear without a stethoscope. Sometimes you'll walk into a room and you'll hear somebody wheezing without the stethoscope, or you'll hear a stridor, which is a more intense sound, sort of like wheezing, but just a little harsher, a little louder. So I don't hear any of that. Another assessment you can make is as you walk into a room and you're standing at the foot of the bed, watch how the chest rises and falls. Now, if both sides rise equally, symmetrically, that's normal. An unexpected finding would be that one side's working a little harder than the other, or even a lot harder than the other. That means one lung is expanding and the other one isn't. So we're worried maybe about a pneumothorax or a problem like that. I don't see any abnormalities, any abnormalities of the chest wall. So that's all good. Our next step is going to be palpation. Now we palpate all the muscles of the chest. What I'm feeling for is crepitus, which would be like a crackling underneath the skin, or any kind of friction rub. Um, those are never normal. Those would be signs of problems, and I can feel in the back as well, over the scapula in the back. And I'm not feeling anything abnormal. While I'm palpating, I can check chest excursion. Okay, I'm putting my thumbs together on either side of his spinal, his vertebral column. Take a nice deep breath in for me. And my thumbs are moving apart. Breathe out. Okay, and they move back together. Now, I'm going to do that in front as well. Okay, go ahead and breathe out, in. See my thumbs move apart, out, yeah. And again at the angle, yeah, the costal angle. Okay, very good. Okay, and at this point, while we're palpating, we're also going to assess tactile fremitus, which is a vibratory feeling. You want to make sure that it's the same on both sides. So I want you to repeat a phrase after me. Can you say boy, oh boy?
Boy, oh boy.
Some people like 99. Go ahead.
Boy, oh boy.
Okay, and in back, right between the shoulder blades.
Boy, oh boy.
And?
Boy, oh boy.
Okay, and everything was equal on both sides. I did feel a fremitus. It was not exaggerated, but it wasn't absent. It was good. It was a nice normal response. After we palpate, we percuss, and we're just going to go, here's the clavicle. We're going to start at the first intercostal space. I want you to take a deep breath in and hold it, and I hear resonance.
Sorry.
That's okay. Okay, I'm going to do it on the other side. Okay, and now in the back, okay, I want you to take a few normal breaths and take a little bit of a break, okay?
Mm-hmm.
When we percuss in the back, we're going to percuss all the way down the mid-scapular line, okay? And we're going to note where the resonance changes into like a flat sound. We're going to mark that. And then we're going to go and make sure that that's the same on the other side. So I want you this time to take a deep breath in and hold it. Okay, so right about here, I'm sorry. Yeah, I thought I had like a little marking pen. I do. I'm just going to mark right there. Okay, now take a few normal breaths. When you're ready, let me know, okay? Okay, now I want you to breathe all your air out and hold it. And we're going to start where? Okay, so right about there, I could hear resonance again. Okay, now take a few normal breaths, and we're going to do it again on the other side. I'm going to have you breathe in and hold it. And you tell me when you're ready. Okay. Okay. Nice resonant sounds. Okay, right there. Okay, now I'm going to have you take a few normal breaths. Okay. And we're going to percuss back up. You're going to breathe all your air out. Now hold it. Okay, so right about there. All right, so they're equal on both sides, and that's the important assessment to make there. We're also going to measure. It should be between 3 and 5 centimeters. Now, I had a measuring tape. Here it is. Okay. So, I have 4 centimeters. 4 centimeters. Excellent. Okay. Now, the last part of our assessment is going to be auscultation. Okay. And you can start in the front, in the back, kind of whatever's handy. What you want to make sure you do, though, is work systematically. I like to start at the top, move my way down, and I like to compare one side to the other before I move on to a new area. That's very important because you want to make sure that those lungs are clear or equal bilaterally, and if they aren't equal, you need to note that and note which side is more diminished. Okay. So I'm going to start in the front. I'm using the diaphragm of my stethoscope. Nice deep breath. Okay. Okay. Nice vesicular breath sounds at this point. Okay, a little bit of wheezing on expiration. Okay, definitely some wheezing. Okay, and I'm listening back. So I heard a little bit of high-pitched wheezing on expiration. Nice deep breaths. And I'm hearing just normal bronchovesicular sounds up top. Okay, little wheezing here. Okay. Okay, definitely some expiratory wheezing. Other sounds that you might hear on assessment. Yeah, what I heard mostly was I heard bronchial breath sounds right here, bronchovesicular breath sounds. I started hearing vesicular breath sounds, but down here all the way in the bases, bilaterally, I heard some expiratory wheezing, and that usually means a constricted airway peripherally. Now, other sounds you might hear, common sounds are crackles or rails, and they kind of sound like your hair crunching together. Bronchi or gurgling sounds. You can also hear high-pitched wheezes sound very musical. Low-pitched wheezes can sound like a snore. And there are some good audio files on the internet of the different breath sounds. One last test that we're going to do is a test of vocal resonance. And I'm going to listen through the lung fields while Mr. M repeats the phrase 99 for me, okay? Okay.
99, 99, 99, 99.
Slower. Sorry.
99, 99, 99, 99, 99, 99, 99, 99, 99,
Okay.
99, 99, 99, 99, 99, 99, 99, 99.
Okay, and this sounds very kind of muffled and sonorous, like there's bees, buzzing. If it sounds very clear, if you can hear 99 very clearly, that's usually not a good sign. That usually means there's some area of consolidation. So another sound that you might hear is called whispered petriloquy. And for the interest of saving time, I'm just going to do the basses down here. I'm going to ask him to whisper 99. Go ahead.
99, 99.
Okay, and I really couldn't hear that word distinctly at all. If I were to hear it really distinctly, 99, I would be concerned. So anyway, that is basically the respiratory assessment. Thank you, Mr. M, for being our patient today.
You're welcome.